Hello everyone, and welcome to this week's webinar, Spinraza for the treatment of spinal muscular atrophy in pediatric and adult patients. This webinar will provide an in-depth explanation of the drug Spinraza, nusinersen, by discussing its genetic mechanism of action and how it effectively treats individuals with spinal muscular atrophy. Now, before we get into the main topic, we'd like to provide you with a brief introduction and description of our webinar format. This webinar was created by medical genomics students from the University of Toronto, Clarissa Chan, Claire Sheen, and myself, Chera Somerville, with the aim of offering healthcare practitioners a resource to learn and fully understand the mechanistic action of different therapies for genetic diseases. Should you have any questions during the webinar, please do not hesitate to contact us at mechanismsinaction@gmail.com. Using our academic training in genetics, we aim to provide the clinical community with a general overview of the genetic involvement in spinal muscular atrophy progression, and explore the molecular function of Spinraza treatment to hopefully enhance general understanding of the specific molecular targets and effectiveness of Spinraza. We will also discuss some of the clinical trials for Spinraza, patient side effects, and look into what coverage looks like for Canadian patients. We will end with a brief summary and link to some interactive questions. To preface the content of our webinar, it is important to point out that we will be providing a brief introduction to the genetics involved in spinal muscular atrophy. Should you have any additional questions or would like to explore the topics we touch upon further, a great resource for concepts in molecular genetics is the 4th edition of the Human Molecular Genetics textbook by Tom Strachan and Andrew Reed. For more publicly available sources, please visit the NCBI bookshelf to access Understanding Genetics, a New York Mid-Atlantic Guide for Patients and Health Professionals. Spinal muscular atrophy, SMA, is a term that encompasses a group of genetic diseases which are characterized by muscle atrophy, wasting, and weakness that worsens with age, resulting from the degeneration of motor neurons located in the spinal cord and brainstem nuclei. As you can see depicted in the image, this SMA-affected motor neuron has undergone some degeneration and correspondingly the muscle has wasted away. This will contribute to a delay of gross motor skills and limited mobility for the individual. SMA is primarily inherited in an autosomal recessive manner, meaning an individual requires 2 copies of the abnormal gene for the phenotype to develop. From the pedigree presented on the screen, you can see that the parents in the top row were both unaffected carriers, meaning they each had 1 copy of the mutated gene, and this gene of interest will be discussed in the coming slides. You can see that both of those mutated copies were passed to their daughter on the bottom right, giving her the SMA phenotype. This disorder is the primary genetic cause of infantile mortality. The most prevalent cause of SMA, which occurs in about 95% of cases, is a deletion in both copies of the survival motor neuron gene, SM1, located on the Q arm of chromosome 5 and codes for the survival motor neuron protein. Chromosomes, which carry the genetic information in each cell made up of DNA and protein, both have 2 arms separated out into the P arm, coming from the French petit meaning small, and the Q arm, which stands for Q, meaning tail. Now, rare SMA patients can be compound heterozygotes, with a deletion in 1 copy of the SMN1 gene and a point mutation found in their other copy of the SMN1 gene. In both cases, the SMN protein is rendered non-functional. It is important to note that SMA can be caused by aberrations in other genes. However, we are focusing on the primary causes of this disorder. Again, in cases of SMA, inadequate amounts of the SMN protein are produced, which inhibit proper functioning. Prior to discussing how this loss of protein contributes to the phenotype, it is important to understand how protein is made. To make the SMN protein, the SMN1 gene is transcribed into pre-messenger RNA in the nucleus, which contains both coding regions, exons, and non-coding regions, introns. As you can see in the figure, the top segment depicts the DNA, which includes both of those exons and introns. Essentially, this double-stranded DNA becomes unwound, which allows for the production of a complementary single-stranded RNA molecule to be coded for in the 5' to 3' direction. This pre-messenger RNA undergoes a processing event, which includes 5' capping, protecting the mRNA from degradation, and poly-A tail addition in the 3' end, which enables export of the mature messenger RNA to the cytoplasm to allow for protein production. Additionally, RNA processing includes RNA splicing, in which the introns, again the non-coding regions of the transcript, are removed, and only coding regions remain to allow for the exons to be joined together. This mature messenger RNA can then be translated into protein, which occurs in the cytoplasm. The SMN1 gene is required for survival and is constitutively expressed in all cells of the body. The SMN protein makes up part of the spliceosome, which is a large molecular complex situated within the nucleus of eukaryotic cells, responsible for the removal of non-coding introns from transcribed pre-messenger RNAs, so that only the coding exons remain to be then translated into protein. SMN also works to inhibit caspases, which are a family of protease enzymes involved in programmed cell death and inflammation. Therefore, a loss of the SMN protein through mutations in the SMN1 gene can contribute to dysfunction in the machinery involved in splicing regulation and can upregulate programmed cell death. The severity of SMA is quite variable, attributed to protein production from the SMN2 gene, a pseudogene located on chromosome 5. Pseudogenes are segments of DNA related to real genes, but through evolutionary processes have lost some or all functionality relative to the fully functional gene. The SMN1 and SMN2 genes are located in a large 500 kilobase inverted duplicated region, the SMN region, which contains significant hypervariability, and therefore no accurate map of the SMN region exists. Individuals harboring a homozygous or compound heterozygous deletion in the SMN1 gene will rely on the SMN2 gene for protein production. SMN2 can modify SMA disease severity as higher SMN2 copy number is associated with a milder clinical phenotype. However, overall, this gene is a lackluster backup because of the minimal amount of protein made. In patients with SMA, mutations in SMN1 are often too severe for current treatments. SMN2, as discussed earlier, is located near SMN1 and is in fact nearly identical. The only difference lies in a single nucleotide change in exon 7, C840C to T. This nomenclature tells us while there is a C found at the 840th coding nucleotide position in SMN1, a T is found here in SMN2. This single base pair difference causes exon 7 to be spliced out of SMN2 mRNA. This results in the production of non-functional truncated protein. Importantly, the exclusion of exon 7 during transcription is incomplete, and 10 to 15% of the SMN2 mRNA transcripts are full length and translated into functional protein. In summary, the severity of SMA is dependent on the production of the SMN protein, and therefore any modifying factor that upregulates the production of this protein will assist to compensate for the lack of protein production from the non-functional SMN gene, ultimately improving the phenotype. As we will discuss later, Spinraza prevents the skipping of the 7th exon in SMN2. Here we are only depicting one copy of the gene, and for SMA patients, this would occur in both copies. There are also different types of SMA correlating with different levels of severity. Type 1A is a congenital form of SMA. It is most severe and starts before birth. SMA type 1B, however, is the classic form of SMA, sometimes labeled as infantile SMA or Werdnig-Hoffmann disease. In SMA type 1B, infants often appear normal at birth and develop hypotonia during the first few weeks of life. Additional SMA types include type 2, type 3, and type 4, which are each successively milder and have a later age of onset. Now that we have reviewed the molecular genetics involved in SMA, we will now move on to an overview of the primary treatment for SMA, Spinraza. Spinraza, nusinersen sodium, is the leading treatment for SMA marketed by the company Biogen Idec, a multinational biotech company which specializes in the discovery, development, and delivery of therapies for the treatment of neurological diseases to patients on a global scale. Spinraza was approved by the FDA in 2016 and is currently used as a therapy for SMA in both pediatric and adult contexts. Essentially, Spinraza works by increasing the amount of functional survival motor neuron protein by ensuring inclusion of exon 7 into the protein, ultimately targeting the direct cause of the disorder. Spinraza is administered through a lumbar puncture injection, which allows the drug to reach the central nervous system through spinal fluid, as depicted on the image of your screen. Spinraza is then taken up by motor neurons and travels inside the nucleus, where it actively targets SMN2's pre-messenger RNA to promote proper mRNA splicing and leads to the inclusion of exon 7 in the SMN2 mRNA. Spinraza is an antisense oligonucleotide, defined as a short single-stranded DNA molecule that interacts with messenger RNA to prevent translation of a targeted gene. The binding of Spinraza is sequence-specific, attaching to a downstream area of exon 7 in the SMN2 pre-mRNA. As depicted in the figure, this area is an intronic silencing sequence that regulates the splicing of SMN2's exon 7. Spinraza contains the DNA sequence complementary to this region to enable efficient binding. The binding of this drug prevents heterogeneous ribonucleoprotein particle, or hnRNPA1, from binding to the SMN2 messenger RNA. Heterogeneous nuclear ribonucleoproteins are complexes composed of RNA and proteins present in the cell nucleus that bind to pre-messenger RNA transcripts, serving as a molecular signal that pre-mRNA is not yet fully processed and therefore cannot be exported to the cytoplasm. Preventing the binding of hnRNPA1 enables the processing of full-length mature SMN2 messenger RNA after splicing that can be made into an SMN protein. In other words, Spinraza is able to increase the proportion of SMN2 messenger RNA that contains exon 7, resulting in increased levels of full-length functional SMN protein. The efficacy of this drug has been demonstrated in the CNS of Spinraza-treated transgenic mouse models. Furthermore, higher levels of SMN2 messenger RNA and SMN protein were observed in the spinal cord tissue of 3 infants who were treated with Spinraza in a Phase 2 clinical trial in comparison to untreated infants. An ongoing Phase 2 Nurture clinical trial has preliminary results indicating Spinraza's efficacy in being administered early on before symptoms occur. A total of 25 subjects genetically diagnosed with SMA, either only 2 or 3 copies of SMN2, were administered Spinraza during pre-symptomatic infancy. With a median follow-up time of 2.9 years, all participants were able to sit without support, while 92% walked without assistance, and an 88% were able to walk independently. However, 8 infants reported to suffer from adverse events following treatment possibly related to Spinraza. Despite this, researchers indicate that these results support the notion of proactive treatment immediately following a genetic diagnosis of SMA. The ENDEAR study was conducted on 121 infants with SMA. Researchers measured motor milestone responses based on results from the Hammersmith Infant Neurological Examination in infants treated with Spinraza and event-free survival time, which was the time of death or use of permanent assisted breathing. 51% of infants who received the drug, compared to 0% in the control group, had a motor milestone response indicating improved motor function and the efficacy of Spinraza treatment. Infants in the treatment group also had a higher likelihood of event-free survival and higher likelihood of overall survival. In addition, better outcomes were observed in infants who received treatment earlier. An additional study we will explore is the CHERISH study. The CHERISH study was conducted on 126 children with SMA that exhibited symptoms after 6 months of age, which is considered later onset. The children were randomized into a Spinraza treatment group or a control group without treatment in a 2-to-1 ratio. The change in motor function from baseline using the Hammersmith Functional Motor Scale Expanded, in which higher scales indicate better motor function, was measured. Researchers observed an improvement of at least 3 points in HFMSE scores in 50% of the children in the treatment group compared to 26% in the control group. Adverse events incidence rates were similar in the Spinraza and control groups. Despite its proven therapeutic efficacy, Spinraza can also have severe various side effects associated with its use. One kind of side effect is coagulation abnormalities and low blood platelet count. In previous sham-controlled studies with SMA patients, 16% of patients developed a platelet count below the normal baseline compared to 14% of sham-controlled patients. An additional side effect of Spinraza use is renal toxicity. Previous sham-controlled studies found that 58% of Spinraza patients had increased urine protein, while this percentage was lower at 34% in sham-controlled patients. Other side effects include lower respiratory infection and constipation, as observed in over 20% of patients treated with Spinraza. A higher proportion of serious atelectasis reactions have also been observed in Spinraza patients at 18% in comparison to only 10% in controls. In a later onset controlled study of Spinraza, most common side effects include pyrexia, vomiting, headache, and back pain. Furthermore, due to Spinraza's method of administration, post-lumbar puncture syndrome has also been reported, which includes perforation of the dura mater, persistent leak of the cerebrospinal fluid, and intracranial hypotension. The use of Spinraza may also adversely affect growth when administered to infants, as this finding was observed in a controlled study. It is recommended by both the Spinraza website and the FDA to monitor patients through measuring platelet counts, performing coagulation laboratory testing, and quantitative spot urine protein testing. Now that we have covered both the side effects and the clinical trials surrounding Spinraza, we will now go through coverage and cost. A bit of information about the drug novelty. Spinraza is currently included in 1 NDA, and there are currently 8 patents in the United States protecting this drug. Spinraza currently has 527 patent family members in 29 different countries. The cost for this medication is $750,000 for the first year of treatment, with subsequent annual treatments dropping to $375,000 per year per treatment. The first year of treatment is significantly more pricey as it requires 6 doses. Specifically, the initial 3 doses, as depicted in this figure, are taken 14 days apart from each other, followed by the 4th dose 30 days after the 3rd one. Moving forward, Spinraza is then to be administered every 4 months. Subsequently, only 3 doses of the medication are required after the first year. The recommended dosage of Spinraza is 12 milligrams or 5 milliliters per administration. This price reflects 5 central elements that pharmaceutical companies use when deciding high costs. First, this medication is developed by one sole biotechnology company. Second, Spinraza is considered the best treatment available for SMA. Third, the medication is only necessary for a small proportion of the population, often discouraging rivals to develop competing treatments. And fourth, the drugs are sold through a closed distribution system. Finally, pharmaceutical companies aim to maximize profits. While costs may appear astronomically high, in Canada, Spinraza is only covered for SMA patients in 4 provinces. Quebec provides coverage for all patients, while in Ontario, Alberta, and Saskatchewan, automatic coverage is only provided for SMA patients under the age of 18. However, patients in the latter 3 provinces can apply for coverage on a case-by-case basis. To conclude, Spinraza is a unique antisense oligonucleotide drug that treats spinal muscular atrophy. This webinar discussed the genetic basis of SMA along with the molecular function of Spinraza. In addition to a review of clinical trials conducted on Spinraza, this webinar also addressed some of the negative side effects associated with its treatment, its high cost and coverage in Canada. Despite these side effects, Spinraza remains the top treatment for SMA. Its novelty for targeting the splicing mechanism of the SMN2 gene makes Spinraza an effective treatment that is able to increase the amount of SMN protein and alleviate some of the muscle atrophy associated with SMA. Thank you very much for taking the time to explore the mechanistic action of Spinraza in treating SMA. We hope you have gained an improved understanding of the utility and potential ramifications of prescribing Spinraza for patients with SMA. Please do not hesitate to contact us through email, mechanismsinaction@gmail.com, if you have any additional questions or comments surrounding the utility and function of Spinraza. We have attached the references used in the preparation of this webinar. Additionally, we encourage you to visit this link to assess your understanding of the concepts presented within this webinar. This webinar was created under a CC BY SA license. Thank you so much for joining us.